So molecular diagnostics really fit into different categories depending on where the test is actually run. You have point-of-care diagnostics, and people are very familiar with those if they go into a hospital and you have point-of-care diagnostics at the bedside or point-of-care diagnostics, in the actual hospital lab. And some of the more esoteric diagnostics, the most advanced diagnostics that would be used today and even tomorrow, in molecular biology really are run in single labs, and that's usually known as a reference lab model or a CLIA lab model. And those are done in cases where the technology is so sophisticated, it's sort of way ahead of the point of care curve. It's not kittable per se, it's not point of care yet, but in most, if not all cases, people can see a time horizon over which those would be those point of care technologies or kittable technologies. And so in our case, that was the case with Core CAD. We're a reference lab model. We're the only place in the world that can run the Core CAD test. In the case of Oncotype in Genomic Health, it's the same thing. They are the only lab in the world that runs the Oncotype test in a reference lab model. One of the things that becomes very important in the coverage strategy for those products is that you are, in fact, the service provider. So CardioDx is the only service provider for Core CAD. That means there's an interesting aspect to your Medicare coverage decision in the U.S., the way that the CLIA rules work. Because you are the only service provider, the Medicare contractor that's associated with the region of the country or the jurisdiction of the state where you provide the service, so in this case, California, that Medicare contractor has the decision authority over your coverage and payment assignment at the time that you're actually getting your coverage decision. Now, there are some moving parts around this in terms of differing legislation and some things that are in evolution around this moving forward, but at the time that we received our coverage decision, that was in fact the situation. At the time that we received our coverage decision, the Medicare contract for California, or the MAC for California, was held by a company in South Carolina called Palmetto. And Palmetto actually gave us a positive decision and our payment decision at the time because we are the service provider in California for Core CAD. The net impact of this is that you have one Medicare decision as the service provider in the state that allows you to actually have national impact, meaning every patient that gets Core CAD in every state in the United States, those samples come back to California and they are covered associated with that California Medicare contractor's original decision about Core CAD in CardioDx in California. So in effect, it becomes sort of a de facto national coverage decision, even though technically it's not called that. So at the time that we received our Medicare payment assignment, it was done essentially simultaneously with the coverage decision. It's not always that way, and in fact, many commercial health plans, you will know that you are covered before you ever have a contract, and it's the contract discussion and negotiation that it really involves your pricing or your payment level. In the case of our Medicare decision, it all happened all at once, and you're not signing a contract per se with Medicare. You're getting a decision about your product and the coverage status and the payment level from Medicare. So it was really critical when we gave our submission to Medicare that we addressed the economics associated with the payment that we really were seeking at the time that we submitted the rest of the evidence package. And so we were very pleased in that Medicare chose very much a payment level that we felt was well aligned with our economic story, with our economic value to the system in terms of our cost effectiveness thresholds. And so we were very pleased with that because it means that they were making decisions on the basis of the product's value to the healthcare system. And as innovators, that's what's really important, I think, is that we want to be paid what's fair according to the value that we provide the healthcare system, not just the quality, but the value also. And so the economics become a critical part of that submission to a payer.